Good morning, everyone, and I would like to thank the Scientific Committee of AIOS for accepting our instruction course. This hall is a little bit difficult to approach, I know, but it's a good hall to have a discussion and have a presentation and session. As Dr. Kim highlighted that the prevalence of diabetes and diabetic retinopathy is very high. As such, in the whole global scenario, it is increasing, and in India, it is in a hot area. If you see that map, India is already in red. Right. When it comes to India and see what is the prevalence of diabetic retinopathy, we have among diabetics at least 1/3 will have some form of diabetic retinopathy. That's why this screening is very, very essential. And second, the incidence of PDR and DME is almost like 7%. So it's very, very common in all diabetics. And vision-threatening diabetic retinopathy is almost about 10%. So everyone be well-versed with diabetic retinopathy, especially when the patient diabetic walks into the clinic, you should manage yourself because every ophthalmologist should be ready to screen. And 90% of the diabetic retinopathy can be followed with general ophthalmologist. This point I want to highlight. It is not a retina specialty management strategy. And ETDRS has used this classic 7 fields for assessment and classification of diabetic retinopathy, which we will little bit highlight on it. And the macular grid is used to define yourself whether it is a significant macular edema or not. With the grid, different lines are there. The central 500 microns, and there is a dashed line which is 300 microns, and 1 disc area and 2 disc areas in this slide. But what is more important is diabetic retinopathy severity scale, which is an international classification, but ETDRS defined it a little bit differently than this. If you see here, if there are no apparent diabetic retinopathy, means there are no abnormalities are there. So if you do not find any signs of diabetic retinopathy, then you will say no apparent retinopathy. When it comes to mild non-proliferative diabetic retinopathy, it is microaneurysms alone are present, means there are absence of retinal hemorrhages, hot exudates, or any other signs like venous bleeding or IRMA. If it is moderate, means then it is microaneurysms plus the other non-proliferative changes are there. In that, we will go to the severe non-proliferative diabetic retinopathy, where you will see that at least the retinal hemorrhages should be more than 20 in 4 quadrants, or venous bleeding in 2 quadrants, or IRMA in 1 quadrant. These 3 are classic, but the importance of all these 3 we will tell you in more detail. Then any new vascularization is proliferative diabetic retinopathy. So when you see the clinical signs, you should look for microaneurysms, intraretinal hemorrhages, hard exudates, and cotton wool spots. Though cotton wool spots, we do not give so much importance in classifying diabetic retinopathy. These are, if you see the pictures here, there are very early changes of non-proliferative diabetic retinopathy, where microaneurysms are very few, and if you see the hemorrhages are also there. But if you see the red-free photographs, more or less a lot of signs they get highlighted. If you see the retinal hemorrhages, it's in ETDRS classification, it's very classically given example, standard photographs to classify whether it is mild retinal hemorrhages, moderate retinal hemorrhages, or severe retinal hemorrhages. And these two are, the first one is, the left one is mild, and that is moderate retinal hemorrhages and severe retinal hemorrhages. Whenever you see more than 20, you can count actually, more than 20 retinal hemorrhages in a given quadrant, it is considered severe retinal hemorrhages. That is important in classifying diabetic retinopathy. Yeah. And there is some signs of, no problem. Intraretinal microvascular abnormalities similarly been classified as mild, moderate, and severe. Hard exudates also been classified as early and very standard of more severe hard exudates. Here you can see the hard exudates in this picture. As I told you, the color certain times masks the highlight the findings, but red-free really highlights the findings very well. Now we come why these three signs are important. One is 4-quadrant severe retinal hemorrhages, 2 quadrants venous bleeding, 1 quadrant IRMA. IRMA is very, very essential, and these three findings, if they are, one of them is present, it is classified as severe non-proliferative diabetic retinopathy. If more than 2 are present, any of the 2 of the 3, then it is called very severe. Why should we classify this in the clinic? This is the reason. If you see the severe retinopathy, non-proliferative diabetic retinopathy, the progression for PDR is very less, 15%, whereas in very severe non-proliferative, within 1 year, this patient's likely to develop proliferative changes. That's why it requires either a closer follow-up or you commit for treatment that we will later on discuss. And when there is a diabetic macular edema, again you should identify whether it is a mild, moderate or severe depending upon the retinal thickness and the hard exudate location from the center of the macula. And ETDRS has clearly defined this definition. Everyone knows that what is clinically significant macular edema. In this, what is more important is the retinal edema or the thickening. If retinal edema should be observed, if retinal edema is not there and hard exudates are present, then probably it is a responding diabetic macular edema. And with the advent of OCT, OCTA, and now we further classify the diabetic macular edema, which again in the management we will highlight why this classification is important. Then ischemic maculopathy should be identified in all the cases, you should not miss. And diabetic macular edema should also be knowingly different stages should be seen on OCT, and this is probably a more useful classification in typifying the diabetic macular edema on OCT, either focal thickening, diffuse non-cystoid or spongy macular thickening, diffuse cystoid thickening, again traction, either point traction or a diffuse traction, and serous retinal detachment on OCT. So ETDRS and the International Diabetic Retinopathy Classification, they differ by a very small whisker, but if you see the grades, mild, moderate, severe, and very severe non-proliferative diabetes. Till here, it is non-proliferative. Proliferative, again, it is, in general, it is called proliferative, but it is early proliferative, high-risk proliferative, or advanced proliferative diabetic retinopathy that need to be identified. How do you identify proliferative? Any neovascular development, you should consider this as a proliferative retinopathy. But once there is a fibrosis development, then it is high risk or more severe diabetic retinopathy, proliferative diabetic retinopathy. This is a little bit advanced case of proliferative diabetic retinopathy. And these cases may be associated with vitreous hemorrhage or a tractional retinal detachment, which again requires a management which is different from a regular photocoagulation. With this, I would almost close this presentation by saying that different steps are given. You need not follow all these steps. Like if you, the scoring on ETDRS, which is very, very complex actually. That's why I made it more simplified for you to understand in the clinic and then strategize your management. With this, I would like to conclude this. And if there are any questions, I'll answer.
Any questions?
Vishali, you can ask if they don't want to ask.
So, Dr. Babu, like you told us the ETDRS classification, mild, moderate, severe, 2-quadrant, 3 quadrants. In practice, do you actually do that?
Mostly I do. Because this is important, because whenever these patients come at the first visit, I always go for fundus photography. That is one standard practice which I would like to do, because nowadays we have the wide field fundus photograph, so it's less likely to miss the findings. Second, the advantage of wide field is we can enlarge and see how many actually the numbers are happening. And this will alert me first. And I will see whether this patient is available for a regular follow-up or not.
So wide field is an expensive camera, or ultra wide field. So what would you recommend for the general ophthalmologist? Because diabetes is no longer a retina specialty. It has to go to the comprehensive.
We have cameras which are very, very economical, or even nowadays smartphone photography is another thing which you can have. Because what will happen is in your busy clinic, certain times you may not be able to screen all the fundus. So it's better to tell your assistant to take the photographs and then you reassess. That will help you much more in picking up and not missing the lesions. That is more important.
Thank you. Any questions for Dr. Yes, please.
It's actually a doubt, Dr. Ajit. This IRMA, sometimes it becomes very difficult to diagnose, and it changes the classification from non-site threatening to site threatening DR.
IRMA?
Yeah. It becomes
IRMA,
a severe
if it is there, yes.
Yeah. So how do we get it between those hemorrhages?
Yeah,
clinical tips?
That's why I always suggest you for a red-free photograph.
Between those spots, what is that which should tell me that this
is
IRMA?
Usually it also will not cross the vessels, but you should identify a vascular network from a hemorrhage. That by enlargement and red-free photograph, definitely you can identify. If you are still in doubt, it's better to have a angiography or
Thank you.
OCT. Dr. Brijesh, he is a retina specialist, so don't worry. He knows how to assess, but he suggested, wanted it that angiography should also be done in these cases if you are in very doubt.
Thank you. Thank you, Dr.